The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this international practical pediatric endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow we're going to cover the endocrine emergencies, mainly calcium, electrolyte decay, and hypoglycemia. So 8 modules. Onal Shah, Dr. Seema Rai, Dr. Manisha Maurya, and Dr. Jyoti Agarwal, who are part of this program. Dr. Vibha will be joining me once we start the cases. Before we start with cases, we'll quickly go through a basic overview of the hypothalamic pituitary thyroid axis, which basically determines the overall evaluation and presentation. So we all know that the most important regulator is the TRH hormone, which regulates the production of TSH, which then stimulates the production of T4, which is a primary product from the thyroid. Now, from this T4, we have peripheral conversion of T4 to T3 using the monodeiodinase activity type 1, which is then bound to the thyroxine binding globulin. So around 99.7% of T4 and 99.7% of T3 is bound to TBG. So only 0.03% and 0.3% is actually the free form, which is the active form. So the level and the function of thyroid hormone not only depends upon how much you have T4 and T3, but also how much is the thyroxine binding globulin. So conditions which increase or decrease TBG level will have an effect on the overall thyroid functions and assessment in particular. Then thyroid really acts and then it causes suppression of the TSH level. So the first thing to happen in a primary hypothyroidism is the rise which happens in TSH. Next step is that you will have a fall in T4. But once T4 becomes very low, T3 will not fall quickly because body will like to compensate. So the most useless investigation in a child with suspected primary hypothyroidism is T3. So we do not recommend routine T3 evaluation in hypothyroidism. While if we talk about central hypothyroidism, you would expect that you will have, of course, a low TSH with a decrease in the level of T4. But remember, often in central hypothyroidism, you may have bioinactive TSH which comes in. So the TSH may be falsely high up to 20 also. So if your TSH is below 20 and FT4 is low, think of a central hypothyroidism. And finally, in thyrotoxicosis, the most important thing will be, the first thing will be TSH will come down, then your T4 will go up. But remember, because monodeiodinase activity, if it is more, especially in iodine deficiency, the T3 level may rise more. So T3 is very relevant in thyrotoxicosis because you may have a high T3 and a normal T4. This is what is known as T3 toxicosis. So these are things which we need to understand. So in a thyroid function test in hypothyroidism, as I discussed, we have to primarily focus on TSH and T4, and FT4 and TSH will be an appropriate one because we don't want to be confused using the thyroxine binding globulin. While if we talk about thyrotoxicosis, you will need to do TSH, T4 and T3, all of them. So what we recommend is T3, FT4 and TSH. Now, why I'm saying T3 and not FT3? Because the measures of FT3 are usually indirect. They depend upon FT4 only. So they are very unreliable. So for primary hypothyroidism, FT4, TSH. For thyrotoxicosis, total T3, free T4 and TSH is what is recommended. Now, TSH has got a significant variation across the day, but the variation is much lower than the biological variation. So you can do TSH pretty much at any time of the day. And for a given individual, the variation is not very huge. So if you want to do TSH, you can do any time of the day. You don't need to wait till morning, and it is not affected by whether you have taken the tablet or not. But if you are measuring free T4 and somebody has taken the tablet, half-life is short, your FT4 may suddenly go up. So do not measure FT4 if somebody has just taken the tablet. So it has to be before the tablet when you are assessing in that scenario. We all know that there is a huge surge of TRH which happens because of the cold environment exposure. So first 48 hours, the levels will be high and then they will come down. So you should ideally do either in a cord blood if you want to do a screening, or around 72 hours or more. If you're doing a bit earlier, you should actually have a different cutoff. A higher cutoff will be required in that perspective. So if your TSH is above 40 in the first week, 20, 1 to 2 weeks, and 10 beyond that, that is the time when you start considering treatment in that perspective. Children also tend to have higher level, but treatment will only be done if it's more than 10 in most scenarios. The other thing to remember is that there is a log linear relationship between a free T4 and TSH. So as soon as the free T4 goes down, TSH should go up hugely. So anybody who has got a low FT4 should have a TSH above 100, usually above 100. But even if it's about 20, I would say this is primary. But if your FT4 is low and TSH is below 20, that is, it is normal, low or slightly elevated, this could still be central hypothyroidism. This is a big message you should think, because if you have a central hypothyroidism, you do not want to miss a CNS tumor. You do not want to miss a cortisol deficiency, because if you do not treat it, you will have precipitation of adrenal insufficiency with thyroxine treatment. And if your FT4 is high, you expect TSH to be 0, that is thyrotoxicosis. Detectable TSH with a high FT4 is very rare. It is either a TSH secreting tumor or a thyroid resistance, unheard of. So don't worry about that. So if you have a detectable TSH with a high FT4, repeat it before you do something else. Otherwise, the diagnosis is pretty clear. So if you have a low TSH and a low FT4, this is of course central hypothyroidism. If you have again a high FT3 and a low TSH and T4, this is an unusual scenario. Somebody is getting T3 from outside. If you have a high FT4 and a low TSH, this is thyrotoxicosis. Even if you have a normal FT4, T3 may be high and TSH may be low. This is T3 toxicosis. So this is how you can interpret the other way around what I'm trying to do. If you have a high FT4 and a normal or a detectable TSH, this is inappropriately high. This is a rare scenario, TSH adenoma. If you have low FT4 with a normal TSH, this is central hypothyroidism. And then finally, if you of course have a high TSH with a normal FT4, this is subclinical hypothyroidism. And if it's low, it's overt hypothyroidism. So all you have to focus is TSH and FT4 in this slide, and you will get the right diagnosis, with T3 playing a role somewhere, somehow not very important. Now, how do we interpret the neonatal screening? So we should ideally do at day 3. Remember, when you look at serum levels, they are 2 times the typical blood levels. But most assays, when they actually report blood levels, they correct for this. So this is already corrected when you get the report out of it. If your TSH is more than 40, look at free T4, consider treatment. If it's less than 20, 99.9% will be in this category. No treatment is required. If somebody is having an earlier assessment, 24 to 48 hours, then you use a cutoff of 34 rather than 20. Now, if you have a borderline TSH between 20 to 40, repeat it after 14 days. If it's more than 20, so as I said, 40, 20, 10. First week 40, second week 20, then 10. So more than 20, you can consider treatment. Less than 10, no treatment. 10 to 20, repeat after 21 days. Now, if it's more than 20 now, then this is a rare scenario. This is a delayed rise. You may need to give treatment, of course. 6 to 20 is a borderline situation. So ideally, you should do a thyroid scan. And we'll discuss all these case scenarios when we keep on discussing the cases. This is just to make a theoretical basis. You do a scan and treat. Less than 6 does not require any treatment in that perspective. So very important, age-specific cutoff 40, 20, 10. This is what is very important to identify. Now, if you have premature child, somebody with Down syndrome, same-sex twin, hospitalization, you should do a repeat level on follow-up in that perspective. What about prematurity? And this is a very confusing picture because often premature individuals will have a falsely high and a delayed rise in TSH. So here, if your TSH is less than 10, then you repeat at 2 to 4 weeks or when they become term. If it's more than 10, and your FT4 is low. So if your FT4 is less and TSH is more than 10, you have to treat. If it is normal and TSH is less than 10, then you of course repeat. While if you have low FT4 and a low TSH, this could either be a central hypothyroidism, rarely, but most likely this is non-thyroidal illness, very common in prematurity. Here, look at features of MPHD. If it's there, then treat. Otherwise, it's unlikely. So the key message is, if you have clear-cut high TSH elevation and low FT4, treat. In all other situations, be careful because this could be non-thyroidal illness and treatment may not be required in that perspective. Once you diagnose congenital hypothyroidism, you should do a thyroid scan. If it shows ectopic, this is ectopic thyroid, lifelong treatment is required. If it shows increased uptake, this is dyshomogenesis or iodine deficiency. If it shows an absent thyroid, do a thyroid ultrasound. If it shows absent, it is agenesis. If it's present, do a TRAP. If it's present, it is a maternal transient hypothyroidism. And if it's absent, you're thinking of other rarer causes. Very important. Just because your thyroid is absent on a scan does not mean it is agenesis. You should do an ultrasound also because you can have an in situ gland which is not picking up the nuclear material. So now we'll start with the cases. Dr. Vibha, who is a fellow in our department, will now start with the cases.
Thank you, sir. So we have a first case, a 20-hour girl and was born in our NICU, and we got a reference call for this. And NICU team got an TSH done, and the TSH was 28. So, Dr. Seema, what should be the plan of action in this case?
Good evening once again. Thanks, Dr. Vibha, for this question. Now, we have a 20th hour of life for girl child with a TSH of 28 millionths per liter. So let us have the perinatal changes graph and see whether this investigation should have been ordered, and if at all it has been done, what should we do now? These are the changes in the term, the red line showing in the term changes, and the dotted green is showing in the premature. At birth, there is surge in the thyroid hormone because of suddenly the baby is coming from intrauterine to extrauterine life and prone to hypothermia. So thyroid hormone surge acts as a non-shivering thermogenesis, and this acute and sharp rise comes down by third day and start continuing falling down till third week of life. So ideally, this should have been done in the cord blood or after 72 hours of life. So this we have to repeat, and we repeat it on 14th day with FT4 and TSH. The FT4 was 1.28 nanogram per DL and TSH is 8 milliliters per liter. So the key messages for this patient is, ideally, the screening for the congenital hypothyroidism should have been done after 72 hours. Within 72 hours, the cutoff is 34 milliliters per liter as per ISPE guidelines. So this the newborn require further screening. If this is still between the 6 to 10, we'll see in the future cases. This is the key message that the screening should be after 72 hours, not within 72 hours.
Thank you, Dr. Seema. The key message is very rightly given. So it is very important to screen the TSH after 3 days of life because of the TSH surge. So here's the next case. We have a day 4-old child with a TSH of 22. And when we have repeated the TSH at the day 14, it dropped down to 12. Then we again repeat it on the day 21, it dropped down to 9. And the free T4 was normal. So Dr. Sonal, what should be the plan of approach in these type of cases?
Yeah. Good evening, Dr. Vipa. Yeah, as we have a child who was screened on day 4 with TSH of 22, and as we have rightly seen, like if the TSH level is between 20 to 40, it has to be repeated after 2 weeks. And as shown in this case, it was after 2 weeks, it was 14. So again, as we see the chart, if it is after birth, if it is more than at the age of 4 days, if it is more than 40, you have to start the drug. But if it is between 20 to 40, you have to repeat it after 14 days. And again, if it is more than 20, you have to start the treatment. But in this case, it was between 10 to 20 at 14 days. So we are supposed to repeat it after 21 days. And after 21 days, it was around 6 to 20. And the FT4 was normal. But still, the scan is indicated because it is at 3 weeks also. The child is having a TSH of 20. It was between 6 to 20. So TSH scan showed hemiagenesis of the thyroid gland. And even if the FT4 is normal, we have to treat the child. But if it is less than 6, there is no treatment is required. So all the cases of hypothyroidism, congenital hypothyroidism, we should go for thyroid scan and see for the hemiagenesis.
So key what messages would you like to give?
Pardon?
What key messages would you like to give from this?
Key message is that if the TSH level at day 4 is between 20 to 40, you need to repeat at 14 weeks, 14 days of life. And again, if it is between 6 to 20, then again you need to again repeat at 3 weeks and do the thyroid scan if it is between 6 to 20 at 3 weeks.
And thank you so much, ma'am, for the key message. And definitely, if the TSH is between 6 to 20 weeks, there is a need of evaluation. We have to go for the scan. And if there is a hemiagenesis, we have to go for the treatment. Now, the next case, we have a day 10 child with a TSH of greater than 10. So, Dr. Jyoti, this is, and the free T4 is 11. And the nuclear scan showed no thyroid tissue. So what should be the plan of action in this case?
Thank you, Dr. Biva.
And how would you like to manage this case?
So we should, in this case, the plan of action should be to start the drugs as soon as possible, to start the thyroid hormone. We shouldn't delay the treatment beyond 2 weeks of life because that can lead to developmental and neurological sequelae. And levothyroxine is the drug of choice. There is no role of there is no better role of T3 over T4, and we should stick to the specific brand, as different brands have variability of thyroid hormone, and tablets should be given because syrup is in the unstable form, and the dose should be 10 to 15 microgram per kg per day. And the lower doses should be used for dyshormonogenesis and higher doses for dysgenesis. And the time.
How should you follow up the case and what should be the dose titration?
So dose titration can be based on free T3 level, T4 level. So in this case, since free T4 level is 10 picomole per liter, so we should start the dose at 8 to 10 microgram per kg per day, and we should titrate accordingly.
I think this is a very important message which Dr. Jyoti is giving, is that we should actually look at the FT4 level before we start treatment. Generally, we say 10 to 15, more than 15. But if it's very low, start at a high dose. And your aim is within the next 2 to 4 weeks, your FT4 should be high. It should become supraphysiological. We don't want to be slow. So that is why, based upon FT4, we have to titrate the initial dose. So on follow-up, this patient... Yeah.
And on follow-up, the free T4 was high. So what should we do, ma'am, now?
So if on follow-up, free T4 is high, then we have to reduce the dose, and they would have been something would have went wrong in this case, because initially in the initial scenario there was thyroid scan does not show the uptake, so we should go for the ultrasound, and this could be a case of apparent athyrosis, because child dose has been reduced and the child is off treatment, so this could be a case of apparent athyrosis.
Okay.
So we should try to follow the approach. So here the thyroid scan has been done, so the thyroid scan does not shows the uptake, so we should go for the thyroid ultrasound, and on thyroid ultrasound, if there is no thyroid gland, then that's agenesis. So this could be a case of TSH receptor antibody that would have crossed transplant placentally, because mother would have been hypothyroid. So I think this could be because of the presence of TRAB.
So, ma'am, what key message would you like to give from this case?
So all absent uptakes are not agenesis as shown in the approach, and we should always confirm if this is a true or apparent athyrosis by the ultrasound.
Thank you so much, ma'am. This is very important that we should not go up only by scan. If scan is showing no thyroid, it doesn't mean that there is no thyroid. We should always go for ultrasound, because as we all have seen that if scan is showing no thyroid, it could be the case of agenesis, or it could be due to the maternal TRAP antibodies. So now moving towards the next case. Now we have a day 4 child with a TSH again with greater than 100, and he was diagnosed with dysharmoniogenesis. So Dr. Manisha, he was treated with levothyroxine of 50 microgram, and after 4 weeks, his free T4 was 21 and TSH was 24. So, ma'am, how should we titrate the dose in this case?
Good evening, everyone. I would like to, at the onset, I would like to thank Dr. Anurag Bajpai sir for inviting me as a panelist. Dr. Vibha, since this is looking like a...
Your video is off.
Sorry, sir, there is some technical problem.
Okay, no worries. Please go ahead.
Okay, sir. Sir, since this is a case of dysharmoniogenesis, and the treatment was started with thyroxine, and as we can see that FT4 has come to the normal range, but the TSH is still in a high range. But in this scenario, if hypothyroidism is there for a long time, since this is a congenital hypothyroidism, TSH may remain high for around 6 months to 1 year. So there is no need to increase the dose of thyroxine which we are giving in this child. And the dose titration in congenital hypothyroidism, which has to be done as discussed earlier by sir also, that initially first we have to monitor the child if we start with the thyroxine hormone at 2 weeks, and then 4 weekly till we are able to maintain the target of FT4 to a higher normal range. And
Manisha really clearly pointed out that the most important thing to look at in this scenario is to look at the TSH as well as T4 level. Now, what we expect in this scenario is that initially T4 should go in a high normal range. We want the FT4 to go into the double range, and then we follow up on TSH. What is important to remember is that TSH may take time because there may be a reset axis of the hypothalamic pituitary axis. So if your TSH is high and FT4 is low, you have to increase the dose. While if your FT4 is normal high, still you continue the same, because this could be a scenario where the HPT axis is reset. This is what Dr. Manisha talked about. While if your TSH has gone low, you have to reduce the dose. So the most important parameter in the first 2 years of treatment is actually the FT4 and not the TSH in that perspective. So now this was the case we were talking about. On thyroxine treatment, there was a high FT4 and a high TSH, and Dr. Manisha nicely said that in this scenario, you should continue the same dose.
Continue with the same treatment.
And this girl again came at 3 years of age with a delayed speech. So, ma'am, what could be the cause of this delayed speech in the same?
Dysharmonogenesis in congenital hypothyroidism is usually may be associated with the Pendred syndrome, in which there is defect in Pendrin gene. And this is associated with a sensorineural hearing loss. So every child with congenital hypothyroidism, we have to screen the hearing at 3 months of age, so that the sensorineural hearing knot may not be missed. In this case, maybe sensorineural hearing loss persisted in this child, was present in this child, and which could be the cause of delayed in speech. So as we can see in this diagram, that Pendred syndrome, this harmonogenesis can be associated with epiphyseal dyskinesis, some developmental problem in hearing assessment. So we have to always screen for the cardiac and the hearing defects in a child with congenital hypothyroidism. So the key message is that there could be a reset of HPA axis in long-term hypothyroidism, for which the TSH level may remain high for a long time. So we have to titrate based on the free T4 levels, and we have to screen for the hearing early at 3 months of age.
Thank you so much, ma'am. Now moving towards the next case, we have a 32-week-old neonate under the routine screening done by the NICU team, and they found that TSH was 7 with a normal free T4. So, Dr. Sonal, what should be the approach in these type of cases?
Yeah, since this is a preterm child, you may expect little variation, little low TSH. Other causes of low TSH are during the illness, Down syndrome children. So whenever we have a preterm child who has been screened and found to be having TSH low, you should not take the TSH within around 7. We should not take it lightly. And if it is like, the approach should be, if it is more than 10, we should do the free T4 level. If free T4 level is low and TSH is more than 10, it is most probably, it is primary congenital hypothyroidism, and you should start treatment as early as possible. But if it is less than 10, and if it is more than 10, and if you do free T4, if free T4 is low, as Anurag sir has already mentioned, TSH is less than 10, it may be a part of multiple pituitary hormone deficiency, and you should do MRI, and it may be a central congenital hypothyroidism. And if it is less than 10, ideally we should repeat it at 2 weeks or when the patient achieves the term. That should be the approach. And if the TSH, if TSH is, in this child it was found to be 14, so we must start the treatment. So the key message here is, in preterm children, you have a delayed rise in TSH level. You may not get the real scenario of the hypothyroidism when we do the neonatal screening around 72 hours of the life. So if you have this condition, we must repeat screen at 2 weeks or when the baby has achieved the term. So that is the key message.
Very nicely put, Dr. Sonal. So, Dr. Vibha, what are the other conditions other than prematurity where you like to repeat a screen?
Sir, trisomy 21, same-sex twin in the hospitalized child.
Yes. So if you have same-sex twin, there's a chance of twin-to-twin transfusion. That's why you may have a falsely low level, and also in somebody who has Down syndrome and, as you said, hospitalized. So this is very important from that regards. Now we'll go a bit about acquired hypothyroidism. We should consider acquired hypothyroidism if somebody has variety of manifestations like growth failure, pubertal disorders, both precocious and delayed puberty, cardiomyopathy and pericardial effusion, hyponatremia, motor developmental delay with high CPK and PCOS. So thyroid is very common across these scenarios. You have to evaluate and assess in that regards. Now, very importantly, you can also see dyslipidemia, high CPK. So often children are diagnosed as Duchenne's and they turn out to be a scenario of hypothyroidism. Hyperprolactinemia, which turn out to be hypothyroidism. Anemia, hyponatremia. So pretty much thyroid becomes very important to evaluate in that perspective. So now how do you approach? The most important tests are two, free T4 and TSH. So if your FT4 is low and your TSH is about 20, this is primary. Very easy to diagnose. Below 20, think of central, do an MRI and cortisol. If it's normal, look at TSH. If TSH is below 6, 6 is the cutoff for adolescents, it's normal. More than 10, consider treatment. If it's 6 to 10, look for risk factors, which are basically TPO positivity, goiter, and a female gender. If they are there, consider treatment, otherwise follow up. So very importantly, there is no need for routine treatment of anybody who has a borderline TSH elevation in that scenario. Now, how much dose to give? It's basically higher dose because it's body surface area based rather than weight. So at younger age, you need a higher dose, and the adult dose typically goes to 1.6 microgram per kg per day. So roughly, if you talk about 100 microgram per kg per meter square per day, that will be the reasonable dose of hypothyroidism. Remember, in acquired hypothyroidism, we do not want to rush treatment. In congenital, because if you are not able to achieve your FT4 level in the first 3 weeks of life, you are dropping IQ points. There you have a rush. Here, if you start at a very high treatment, what problems will happen, Vibha, in that scenario if you treat too quickly?
So the child will develop headache, irritability, will not able to concentrate in classes.
So you will have a tendency of benign intracranial hypertension, slip capital femoral epiphysis, early puberty. And this is what Vibha is studying, is what is the impact of hypothyroidism on height. Puberty may happen early if you treat very quickly. So all this has to be evaluated before you do. So you start at lower dose, especially in severe cases. And very importantly, do not give it with calcium or iron, where you can have a thing, or soy protein. Do not expose the medicine to light. That is why all these medicines are in a black container usually in that regard. So we'll start now with the cases again.
Thank you, sir. So now moving towards the acquired hypothyroidism, we have a 12-year-old girl who came to us with a complaint of increasing weight, and her height was 156 centimeter and weight was 56. There was no other clinical features, and her TSH was 6.4. And she was advised levothyroxine. So, Dr. Seema, it is judiciable to treat this patient with levothyroxine. What is your point of view in this case?
Thanks, Dr. Weber, for the case. Now we have a child, 12-year-old, whose weight is 60 kg and height is appropriate. Now let us have a look. Obesity means we have more adipose tissue in the body. Now this is very much proven in the studies that adipose tissue acts as an endocrine organ. So it secretes leptin, which is a neuroendocrine factor, which stimulates the paraventricular cells in the hypothalamus, secretes TRH, which further stimulates TSH. So the obesity will, because of the leptin increase, would lead to high TSH, but this will not be as high as in the pathological causes. This high TSH with normal T4 and normal T3. So the obesity-induced increase in the TSH is the result of the obesity. This TSH does not lead to obesity, and this is pure compensatory, entirely reversible with the management of obesity and no treatment required. Let's have a look on the flow chart, how we approach such cases. This flow chart is showing we should, if the FT4 is normal, TSH will look, here in our case, it was 6.2. So you should treat if there are risk factor present, like if there is a TPO positivity, if there is goiter, if there is a family history of hypothyroidism, and if there is girl child. In this case, in our case, no other clinical picture was there, no goiter, FT4 was normal and TPO negative. Hence, this patient did not require any treatment. And this borderline TSH is just because of the obesity to increase the BMI, because thyroid hormones are catabolic. So just as a result of the obesity, this TSH is rise, does not need treatment, and toxin should not have been required. Only the weight management, lifestyle modification for obesity is required. So the key message is high TSH is the the effect of obesity, not a cause of obesity, and we should treat obesity. And no treatment is required below 10, and we should treat the obesity, not the L-toxin, not the TSH report.
Thank you, Dr. Seema. Very nicely said by Dr. Seema that we should not treat all the obese children with TSH, just slightly high TSH, that is a borderline elevated TSH like 8, 9 or 10. So moving towards the next case, we have a 10-year-old girl who came to us of complaint of poor concentration in the class. Her height was 136 centimeter and weight was 34 kg, and she was euthyroid. Her TSH was 2.4 and T4 was 16 nanogram per dl, which is lower than the normal limit. So, Dr. Manisha, what do you think? Is it really hypothyroidism, or what's wrong in this case?
Dr. Vibha, I think since the height and the weight and is within the normal range, and the child is in euthyroid, and there is TSH is normal, there is mild decrease in T4 level. T4 level depends, we have to do a free T4 level because the thyroxine binds to the thyroxine binding globulin, albumin, and the transthyretin. Most of the thyroxine is bound to the 75% is bound to the thyroxine binding globulin, and this the conditions which may, as told by sir also, some conditions may increase the TBG level and some condition may decrease the TBG level, and this will interfere with the levels of thyroid. So the condition which decrease the TBG level, the total T4 level may be low. So if we have a child in which if who looks seems to be normal, euthyroid, but T4 is in the lower normal range, we have to get a free T4 level.
As we can see, the free T4 was in the normal range, 12, and TPO was negative.
TPO was,
so,
yes.
ma'am,
so we don't need treatment at present, since both the TSH is in the normal range and FT4 is the normal range. So the
message you would like to give?
We always have to, although T4 is a good valid method of doing the thyroid assessment, but if we are getting T4 in a lower range, then we have to confirm hypothyroidism by doing free T4 level, because T4 depends on the thyroxine binding globulin and albumin, and the conditions which increase or decrease these binding globulins may cause error in the estimation of thyroid assessment. So we always have to do a free T4 level.
Thank you, ma'am. It is very important to do the free T4 estimation in every case. Now, moving towards the next case, we have a 12-year-old girl who came to us with a complaint of lethargy, not taking interest in any activity. Her height was 140 centimeter and weight was 36 kg. Her free T4 level was 6, which is lower than the normal limit, and TSH was 12. And so thyroxine was given for the treatment. So Dr. Jyoti, is giving thyroxine is the right thing, or is anything missing in the approach? What would you like to say?
Thank you, Dr. Viva. So seeing on to the linear relationship of free T4 and TSH level, since the free T4 level is very low, TSH must be very high, but your TSH is only 12. So in this case, we have to think of central hypothyroidism rather than starting with the thyroxine. So we have to evaluate in a line of central hypothyroidism. So,
and for this, we get the cortisol done and it was low. And for this, we get the MRI done and there was empty cella. So for this, what should be the treatment?
So we have to think in if this is a case of central hypothyroidism, the most common cause of central hypothyroidism is multiple pituitary hormone deficiency. So we have to send anterior pituitary hormone assessment, and since MRI is showing empty cella, so we should not start thyroxine initially. We should start hydrocortisone. Followed by that, we should start thyroxine. As if we start hydrocortisone before, it will unmask cortisol level and the child may go into shock.
So, Dr. Vibha, which enzyme does thyroxine stimulates which causes this precipitation of the adrenal insufficiency?
Sir, 11 beta HSD.
So 11 beta HSD2, so which will inactivate the activity. So it will basically inactivate cortisol, and that's why you will have a problem in that scenario. So very important, if you're thinking of a central hypothyroidism, you have to do a MRI before that, and in that scenario, you also have to look at cortisol and treat appropriately in that perspective. So the key messages, Dr. Jyoti?
So when the T4 level is less and TSH is not as high as expected, that is less than 20, we have to think of central hypothyroidism. And in those scenarios, we have to go for MRI imaging, and anterior pituitary hormone assessment should be done.
Thank you, ma'am. Very nicely said that we should get the cortisol levels done to avoid the adrenal crisis, as sir has said. Now moving towards the next case, we have a 12-year-old girl who came to us with a growth failure. Her TSH was greater than 100, but the free T4 was 6, which was very low. So, Dr. Sonal, how should we start the treatment in this case, and how should we do the dose titration?
So this is a clear-cut case of hypothyroidism, most probably acquired hypothyroidism. And since the child has also presented with growth failure, it has to be a long-standing hypothyroidism. So dose for more than 10 years will be 2 to 4 microgram per kg per day. But we don't directly start with a high dose. We usually start with a lower dose because, as you rightly mentioned, that if we start with the higher doses in case of a long-standing hypothyroidism, it might lead to headache and signs of raised intracranial tension. So here we have to start with 25% of the calculated original dose, and then gradually we have to increase the dose. Again, one thing we have to explain to the patient is timing of the drug, because timing of the drug is very important. Child has to take the drug on empty stomach, and child should take the calcium and iron preparation after 6 hours of taking the thyroxine tablets. The thyroxine tablet, how to preserve is also very important, because they should keep it away from the sunlight, direct sunlight. And they have to avoid the high soya protein diet along with when they take the thyroid medicines. So timing is very important, dose is very important, and the timing of the other drug, taking of the other drugs is also very important. So this message should be passed on to each and every parent or the child.
Now again, ma'am, after follow-up of 1 year, the same patient came to us with a TSH of 23, and she came with a report of free T4 of 26.
Yeah.
So what, according to you, has gone with this report? Is it really?
Yeah, so since TSH is 24, it is definitely high, but free T4 is normal. So in these circumstances, it might have occurred that we have to check the adherence of the whether how much tablet, because it might have occurred the child might have swallowed 5-6 tablets or 10 tablets before taking out the report, because she wanted to avoid, because it's a typical adolescent child, she wants to avoid the she wants to be cured of the disease, and to hide this thing she might have taken the higher dose. So we have to check the dose and other things when we get this kind of, we have to check the compliance, we have to check the dose, and the usually how do we check it? Like usually we repeat TSH every 3 monthly and FT4, and depending on the TSH and FT4 level, we increase or decrease the dose. So if in this case it was a high TSH and it was a high T4 level, so we have to check the adherence. As I explained you, a patient might have swallowed many tablets. If it is TSH is high but normal, T4 is normal, you have to continue with the same dose. But if it is TSH is high but FT4 is low, then you have to increase the dose. Now, if TSH is normal, FT4 is normal, again you have to continue with the same dose. If TSH is low and the T4 is high, then definitely you have to reduce the dose. And again, we have to highlight that because being a teenage girl, you have to recently, because FT4 is affected by the recent intake of the drugs, so that we have to check for it. So key message here, yeah, it has to be when we start the thyroxine treatment, it has to be in a long-standing hypothyroidism, except in case of congenital hypothyroidism, where we have to give it within first 14 days of the life. But here, a high dose, but here we have to gradually increase the dose. We start with 25% of the original dose, and then we gradually build up with the dose. Timing of the drugs, empty stomach, and compliance or adherence to the treatment is very important.
Thank you so much, ma'am.
And Vibha, what is the difference in half-life? Because this is very important question from here. What is the difference of half-life of TSH and T4?
Sir,
Which has got a longer half-life?
Sir, this TSH is longer.
So TSH takes up to 6 to 8 weeks to stabilize. So that's why if you take a lot of medicines now, your FT4 will go up. It has a shorter half-life, but TSH will not go down. So this is what the big confusion is. High FT4, high TSH adherence. Very nicely said by Dr. Sonal as well. So now the next important issue is that often we are referred as endocrinologists about scenarios in which thyroid reports are unusual, but then we don't need to know whether it's really because of a thyroid disorder or something else. So in a sick child, you can have a lot of variations which may happen in the ICU. So the key message is do not do a thyroid function test in a sick child unless it is essential. If you do a free T4 and TSH, do not do T4. And you can then look at T3, T4, which causes confusion. So I'm not going to do too much in terms of physiology, just key messages. So what you expect is that TSH will be lower because when you are sick, your cortisol will be high. It will suppress your TSH. TSH will become lower. Assessment is the same. It is not the problem in terms of assay, but you will have a falsely low TSH level. So you may diagnose somebody as central hypothyroidism, or you may miss a primary hypothyroidism. Now, if your levels are more than 10, you are still worried. If it is very low, you are worried. So you have to be very, very careful when you look at TSH. What about T4? The T4 level is also low because your monodeiodinase inactivating activity becomes more. If somebody is sick, the body says, okay, I do not want the increased activity. I want to cut down on the T4 level. It also goes down. TSH is also low. You will assess lower because your assays have a problem in assessment. So you will overdiagnose hypothyroidism in this scenario. So low T4, low TSH, central. Often people will say this is central hypothyroidism. So you have to track it. Don't go by single value in that scenario. FT4 again will be low to a lower extent because TBG is also affected. That's why your total T4 is worse. In this scenario, again, it's not very significant. We don't want to do FT4 routinely. What about T3? Again, T3 will be low and you will have a problem. So generally, all thyroid tests that you do in a sick child within the ICU will be mired by problems. They will be on steroids. They will be on dopamine, which inhibits TSH secretion. They will have stress. Body is trying to conserve energy. So this is important. So how do you interpret? So if you do not have to do testing, do not do it. Otherwise, do both FT4 and TSH. If your TSH is very low, in that scenario, look at free T4. If you have high free T4 and low this thing, this is of course thyrotoxicosis. As I said, FT4 can come down, it will not go up. High FT4, low TSH, very rare. Hyperthermia, tachycardia, cardiac failure, then you will think of it, but this can happen. If your FT4 is normal, don't worry, this is a normal scenario. If it is 0.05 to 0.3, look at cortisol level. If your cortisol is low, it means it is a multiple pituitary hormone deficiency. But if your cortisol is high, that is a normal phenomenon. High cortisol suppresses TSH, so nothing to worry. If your TSH is normal and everything is normal, nothing to worry. This is a normal scenario. If it's 4.5 to 10, again, don't treat, repeat after 1 week. More than 10, we talked about that this is underestimating primary hypothyroidism, but still your TSH is more than 10. This requires further evaluation. FT4 low treat, normal repeat. So look at specific cutoffs for illness. Otherwise, you will be unnecessarily treating somebody who doesn't require treatment, and that may cause worsening in that scenario. So we'll go into this case now, Vibha.
So we have a 10-year-old boy who was admitted in PRC for meningitis, and his TSH was 0.1 and his free T4 was 6. So Dr. Seema, what should be done in this case when you got a call from the PIC? What should be the plan of management?
Ideally, thanks for this case, Dr. Vibha. Sir already has explained, in ICU, we should ideally avoid thyroid hormone assessment. If at all it has been done, how to interpret this? The TSH is very low and the free T4 is also low. So looking at this graph, if everything is low, it looks like it is central hypothyroidism. But we should look at the cortisol level. Cortisol is a stress hormone, which should increase in all the stress. The meningitis is lots of stress on the body. Cortisol is high. So our cortisol is high. So it is a normal response of the meningitis to the patient. But if the cortisol is low, it indicates multiple pituitary hormone deficiency. So this case is all the thyroid, TSH and FT4 is low with a high cortisol. This high cortisol is suppressing TSH and further T4. This is non-thyroid illness. And if at all if TSH and T4, if it should be done if the patient has persistent hypothermia or bradycardia, because sickness leads to tachycardia, not bradycardia. The key message is we should avoid assessing thyroid hormone in the sick patient, and it is a completely non-thyroid illness. We should repeat when the patient improves after 2 weeks.
Other features of sympathetic excess like tremors, eye signs, periodic paralysis and polyuria, these are the scenarios where we have to think of a possibility of thyrotoxicosis. In this scenario, we should think of nuclear scan. But if somebody already has a goiter or an eye sign, the nuclear scan may not be required. In this scenario, if the uptake is increased, we can look at solitary nodule, in which one nodule has having the uptake. If it's a diffuse uptake, it will be Graves. If there are multiple areas of uptake, this is toxic MNG. And if it is decreased uptake, very importantly, this could be a thyroiditis-like scenario in which we do not need extensive evaluation, assessment or management. So very importantly, we need to look at the nuclear scan, and then based upon the finding, we can identify. Why do we need to identify thyroiditis? Because this scenario does not require treatment and we can manage them effectively, and they will follow up, will give you a good picture in that regards. So Dr. Vibha, we can continue from there.
So we have a day 12-old child who came to us a few days back in our OPD with a complaint of irritability. Her birth weight was 2,800 grams and now it came down to 2.2 kg. His heart rate was 168 per minute and there was proptosis. Free T4 was quite high, 44, and TSH was less than 0.001. Her mother has Graves and she was treated with the radioactive iodine 2 years ago. So, Dr. Manisha, what should be the plan of treatment in these cases?
Thank you, Dr. Vibha. Dr. Vibha, I think this is, we can see easily that the features
Dr.
of...
Manisha, you are there?
Yes, sir, I am here. Yes, sir, I am here.
Again, Dr. Manisha, are you muted?
No, sir, I am not muted. Am I audible?
Yeah, now you are audible. Yeah.
Sir, since the weight has reduced more than 10% in this child, and the features of hypothyroidism is also present, and the analysis shows that the baby is suffering from hyperthyroidism since FT4 is very high and TSH is very, very low. And the mother was treated with radioactive iodine, and since the mother was treated with radioactive iodine, sometimes the TRAB antibody, the thyroid receptor stimulating antibody, may persist in the body of mother for 2 years to 5 years. So the reason for hyperthyroidism in this baby could be the transfer of TRAB antibodies through placenta, because the TRAB antibody, the T3 and the anti-thyroid drug all can pass through placenta and can cause features of hyperthyroidism. If this mother would have been on hyperthyroid drugs like methimazole, then the presentation of this baby could have been initially hypothyroidism because of the effect of methimazole, but this hypothyroidism would have weaned off because methimazole, the half-life is only 2 days. So in such babies, we have to do repeat the thyroid assessment at 2 weeks. if we have a history of mothers with Graves' disease who have been treated for thyroid radioactive iodine or been on treatment of methimazole, and such a child has to be treated, since all the features of hyperthyroidism is present, we have to treat this child with antithyroid drugs and beta blockers. And if the condition is very severe, sometimes we can also add steroid and sodium iodoptate. And this is a transient condition because this thyroid receptor antibody will go off from the body within 6 weeks. So we have to follow the child for the thyroid assessment, and we can gradually stop the treatment over a period of time. So the key message is tremor and weight loss are the features of thyrotoxicosis, as told by Sir also. Eye sign is present in Graves' disease, and the treatment is methimazole and radioactive iodine in hyperthyroidism.
So I think this is a very important message of transient thyrotoxicosis, which is often seen transient Graves' disease. 5% children who are born to mother with Graves' disease will have thyroid dysfunction. Dr. Manisha very nicely said that around half of them will have hypothyroidism, which is basically because of anti-thyroid drug. The other half will have a transient Graves' disease. We'll carry forward to the next case.
We have a 12-year-old girl with a weight loss and a complaint of tremor. Her free T4 was 34 and TSH less than 0.01. She has a thyroid swelling, but there was no eye sign. And she came to us with a tremor. Ma'am, Dr. Jyoti, what would be the plan of action in this case?
So this is the early adolescent girl with weight loss and tremor, who has, which is a case of thyrotoxicosis. Since there is no eye sign, we have to go for a nuclear scan. As Sir has very well said that if there is increased uptake, we have to see if it is a solitary nodule where the uptake is in just in one of the lobe, or toxic multinodular goiter, or Graves. Or if there is a decreased uptake, then there will be tenderness, is there or not, yes or no. And if there is tenderness, this is subacute thyroiditis, no, then there is chronic lymphocytic thyroiditis. So if clinically and on the basis of nuclear scan, if this is a Graves' disease, then our line of treatment is methimazole, and along with that we have to go for beta blockers, and radioactive iodine can be the second option.
So Dr. Vibha, what message will you give to the parents when you are starting methimazole? When should they immediately contact you?
So they should contact us when there is a this jaundice, or there is a this cold sore throat, because there is an increased risk of agranulocytosis in this case within the first 100 days of the.
So first 100 days, if they have a throat pain, immediately get a CBC done. If it's low, TLC is low, stop the treatment. That's a big message that you have to give on that. So clearly, as we discussed, that eye signs suggest Graves' disease. If you have eye signs and goiter, you can avoid scan. The other option of scan is a TSH receptor antibody, which also we are finding to be quite effective in children to identify Graves' disease in that scenario. Next case.
We have this 8-year-old boy who came to us with just thyroid swelling. So, and it moves with, on examination, it moves with tongue movement. So, Dr. Sonal, what should be the approach in this case?
Yeah, since it is a swelling in the thyroid area and it moves with the tongue movement and the deglutition, it is most likely to be thyroglossal cyst. And here we don't require any medical line of management. We have to straight away advise for the surgery to this child. So key message here will be that it moves with the deglutition and the protrusion of the tongue.
And this is a very high risk of malignancy also, infections and malignancy. So thyroglossal cyst requires immediate removal.
Now coming to the last case, we have a 10-year-old girl who came to us with a thyroid nodule, and she was euthyroid, and the TPO was negative, and she was reassured and was sent back to home. So is it, and there was a history that swelling was increasing day by day. So Dr. Seema, is it right to for her to send back to home because she was euthyroid, or should we done anything else in the plan of management?
Thanks, Dr. Vibha, for this case. As we are seeing that patient developed rapid growth. So this rapid progression is the high risk for the malignancy. So we can see the right side that there's a huge lobulated swelling is there, which is rapidly progressive, although the thyroid status and TPO suggest autoimmunity. For the malignancy, what pointers we should keep in mind? If the size is more than 1 centimeter, if the swelling is fixed to the surrounding structure, if there are the cervical or submental or the inguinal lymph nodes are enlarged, if there is a history of low dose radiation over the prolonged time, or there is a family history like RET of genes are present in the men too. If all these risk factors are present, there's a high chance this patient will have malignancy, and we should have gone for ultrasound of the neck and for further scan to see the calcification, the rim, rest of the feature on the scan as well as ultrasound, and if the size is more, finally FNSC guided histopathological diagnosis should have been done.
Thank you, Dr. Seema.
So I think this is a very important message. Thyroid nodules in children are very, very significant because they can be marked. Dr. Bharani is asking, in meningitis, if there is a Waterhouse-Friderichsen syndrome, the cortisol level will be low, how to interpret in those situations? So that would be a difficult scenario. So if you have a cortisol levels which are very, very low, in that scenario, whether you're FT4, and that will be a very rare possibility in a central hypothyroidism to also develop a Waterhouse-Friderichsen syndrome. So I think in that scenario, the first priority will be to correct your hydrocort. First thing you will give is to give hydrocort and then go forward from there. The next is from Dr. Fahimida, who is asking what is the perfect follow-up schedule for transient hypothyroidism. So transient hypothyroidism, 90% of cases are usually permanent, especially if your FT4 is very low to begin with. But if you have maternal TSH receptor antibody, it may cause transient hypothyroidism. Usually, in our experience, by around 6 months or so, your requirement will come down dramatically. So typical follow-up pattern for a congenital hypothyroidism is that you need to monitor levels after 2 weeks, then every month for the first 6 months, every 2 months for the next 6 months. This is how we follow up. And if your TSH is consistently going low, you keep on decreasing the dose. Otherwise, we want to continue till at least 2 to 3 years in that regards. Next question is from Dr. Sajida Abdullah, who is saying if nephrotic syndrome TSH is 9 and FT4 is 1, what should be done? So in this scenario, you are dealing with a borderline situation. So I'll probably wait and watch without giving treatment. I've seen a lot of confusing scenarios in nephrotic syndrome. Hypothyroidism is known as a cause of nephrotic syndrome as well. But I would be a bit cautious. Look at autoimmune status, TPO antibody, and follow-up will be a better scenario in that regards. Dr. Linda is asking, if the thyroid becomes a malignancy, then what do we do? So this is important. So of course, anybody who has a size more than 1 centimeter, has an associated lymph node, has a fixed nodule, you get a FNAC. Then we already discussed that there are various NIH criteria which talk about that. So if you have likely malignant or malignant, you have to go for surgery. So this requires surgery. And then of course, surgery will be determined whether it's a papillary or whether it's a follicular, whether it's a medullary carcinoma. So this is an entirely different scenario. The main message is for a pediatrician, if you have a thyroid nodule, 1 in 10 will have a risk of malignancy. So that's why you have to be very, very cautious in that regards.